Hello coders! Today we are talking about digestive CPT surgery. So as always, we're going to start with the easiest ways to search for a digestive surgery term. Again, top three, the name of the surgical procedure. Since we have a lot of natural orifices and we have some stomas, some new openings to the outside of the body, we can do a lot of scopes like a colonoscopy. We can also look up the anatomic site itself, something like the tongue, the anus, the small intestines. And we can also look up certain conditions. We're going to see hernia repair here, and we're going to see a lot of hemorrhoid repairs as well. Now, most of the main terms are going to be the anatomic site, as you see here. Remember, when it comes to the way that we separate out the body, the respiratory system starts at the nose, goes all the way down to those little air sacs at the end of the lungs, those alveoli. Okay, digestive starts at the lips. It includes everything that's in the oral cavity. This is going to include the entire mouth, the tongue, the dentalveolar structures, our gums, our teeth, our palate, our uvula. Then again, we have our general passage, our pharynx. Then as we go down, we're going to get to the esophagus, the stomach, the three parts of the small intestine, the duodenum, the jejunum, the ileum, and then the different parts of the colon. Okay, so we've got the cecum, which is what the appendix hangs off of. We have the ascending colon that goes up, transverse colon goes across, descending colon goes down, sigmoid colon makes a little S shape, and then the rectum and the anus. But we also have some accessory structures. So our accessory structures are the liver itself, the gallbladder, including the biliary tracts, and the pancreas. We're also going to have codes here for the abdomen, peritoneum, and omentum, because we're going inside of the abdominal cavity. And again, lots of scopes. Any type of scope you can think of that can either go in through a natural orifice, like the mouth or the anus, can go into a new opening that we've made in any part of the digestive system, and also, of course, the abdominal cavity itself. Certain sections of digestive have a lot of guidelines, some of them don't. So the first thing we get to are the lips. There's no real guidelines for the lips, but it does remind us for procedures of skin of the lips, go back to integumentary. Same thing with respiratory. When it's on the outside of the nose, it's integumentary. When it's on the inside of the nose, it's respiratory. For digestive, if it's the skin of the lips, then we're going to do integumentary. If we're going deep within the actual lip tissue, that's digestive. So again, we can do things like a biopsy of the lip. You'll see the word vermilion here. Vermilion is basically the line around our lips and all of the main color of our lips. Vermilion was one of the first main lipsticks that we saw way back when they were using berry juices and things like that. But when it came to the 1800s in the United States, vermilion was still, it's kind of like a very bright red color. So if you see, like, for instance, any movies that take place in the Wild West in the 1800s in, whether it's Texas or anywhere that's considered west of the Mississippi River, a lot of times you'll see women with these very bright lips, and that is the color that we call vermilion. It's also what they call, again, the natural color of the lips. So that's a vermilionectomy, where we're removing that. Now, when you see a lot of these reconstructions here, a lot of reconstructions that happen with the lips and the oral cavity is because of oral cancers. The most common cause of oral cancer is chewing tobacco, because a lot of people, they make a pouch in their mucous membranes of their cheeks. And one of the things that they put in chewing tobacco is fiberglass. And the reason is because it makes these little tiny cuts in the mucous membranes. So the nicotine, when it's sucked in, gets right into the actual blood supply sooner rather than later. But again, so not only are you having tobacco sitting in a place and it's consistently sitting there for a while and then being replaced, you also have these cuts that are being made inside the oral cavity. Of course, we can also do these for different craniofacial anomalies. We're going to see some cleft lip, cleft palates here too, along with the cleft lip repairs that come a little bit further on the page. We also can see this for accidents and injuries, of course. So again, for this, what are we doing to the lip? Remember chilio? Cilio is lip. We don't see it too often. This is one of the main places we are going to see it. But again, you can see this is different repairs of the lip. Here is our plastic repair. This is a cleft lip and nasal deformity. Again, we have different options depending on what the surgeon's doing. Some cleft lips and some cleft lip, cleft nasal deformities can be done in one stage, meaning they can do one procedure and it's relatively fixed. They may have to do another procedure as the child gets older. Other ones, they might have to do skin grafts, they might have to move skin around and do some of those adjacent tissue transfers, things like that. So that's why we have these other stages. So what we need to know is what is the provider doing right now. As we continue on, we get to the vestibule of the mouth. Again, they remind us the vestibule of the mouth is everything outside of the oral cavity and dentio-alveolar structures. This is more of the mucosa of the lips and the cheeks. So for instance, if you've ever gotten like a popcorn kernel stuck in the mucosa of your cheek, this is where we would remove it, because usually it will produce a tiny little abscess, or it could be an embedded foreign body. So this is one of the big ones. The other thing is the frenems. We have frenems on the top and bottom. These are these little connections that connect our top and bottom lip to the mucosal structures. And then we also have a frenum underneath our tongue too. All of these can create problems with eating as children. And so what we need to know is, if we are doing a frenotomy where we're making a little incision in, is which frenum are they doing? Because again, we need to know if it is the top or bottom frenum in the front of the mouth, the anterior portion, or if it's the one under the tongue. And again, this is where we get the diagnosis of tongue tie. Tongue tie is because those frenems just didn't grow quite enough. So the baby has a hard time suckling, whether it's the bottle or the breast. And so it's a feeding difficulty. And so this can be done. It can be done the day the baby's born. It can be done in the weeks afterwards. And sometimes it takes a couple of months for them to really decide that this is the issue. And again, very similar with a lot of other procedures, this is not done unless absolutely medically necessary. And that's because a lot of children have had this done because it was suggested early on, when they were a few weeks old. But as they get older, 5, 6, 7, 8, they're now going back and doing the repairs of these because they took too much tissue out and now they're having trouble tucking. Again, we can do excisions of the different mucosas. Again, how are they describing it? Is it simple? Is it complex? Are we removing underlying muscle? So again, how much are we removing? We have to keep this in mind with a lot of our procedures. When we flip the page, we get to the tongue and the floor of the mouth. Now, again, you can also work for dental, whether it's a dentist's office, orthodontist, periodontist, oral surgery, and a lot of times they're grouped together under the same group name, but they have slightly separate offices. So again, these right here are things that a primary care physician can do, a general surgeon can do, a dentist can do, orthodontist, periodontist, things like that. So kind of keep in mind, this is not necessarily just for a gastroenterologist. So again, we have different abscesses and hematomas. Again, whether it's on the floor of the mouth, it could be extraoral, it could be the tongue itself. Okay, we can biopsy the tongue and we can actually do an excision. Again, excision of the tongue, removing the tongue itself, is something that we would only do for things like extreme accidents and injuries or cancer, because it's not something that we can transplant, and it leads the person to having a lot of problems with communication as they get older. So we keep going on. Ooh. We're going to see some of, again, our other procedures. So one of the big things that we always hear about on TV is gingivitis. So these are the gingivoplasties, where what they do is they basically will take the mucosa underneath where the dentialveolar structures, the gingiva itself, they pull it away, they highly cleanse that area, and they suture it back up. And they do each quadrant. So the quadrants are top, bottom, left, right. And so again, this is something that a periodontist would do, an oral surgeon. This is not usually something that a dentist does. Usually this is going to be one of the subspecialties of dental. Then we get to the palate and the uvula. Again, the uvula, a little boingy thing in the back of our throat. In general, it doesn't do much for us. There are languages around the world that use the uvula to help produce specific noises, but really none of the ones that we are familiar with. So the uvula itself usually just stays in the body unless there's a problem. So the biggest thing that can happen is abscesses. The other thing that can happen is it can become enlarged, a hypertrophy. And the problem with the uvula enlarging is that when the person lays back to go to sleep, the uvula can cut off that air supply, so the person can only breathe through their nose. And so sometimes they remove part of the uvula or the entire uvula for those issues. But again, those don't happen nearly as often. So as you can see here, we have different skin grafts we can use and different repairs that we can do to the palate. We also have our palatoplasties for our cleft palates here. So the cleft palates and cleft lips do have separate codes. They are not combo codes. The cleft lip can be a combo code with the nose, but not with the palate. And again, sometimes they're doing 2 or 3 of these procedures at the same time on the same child so that they can get as many of this done. So again, they're able to start eating normally. All right. Then we get to the salivary glands and ducts. So again, we have 3 sets of salivary glands. We have the parotid glands, we have the submaxillary and sublingual. So sublingual under the tongue, submaxillary under the maxilla, okay, under the jaw, and the parotids, which are kind of like right in front of the ears, but down ever so slightly. So again, which one of these glands are we dealing with? And then what are we doing to it? A lot of times we're draining them for abscesses. The other thing that can happen is like what you see right here, the ciliolithotomy 42330. A lot of people forget that our kidneys are not the only organ that can grow stones. Our gallbladder can grow stones, so can our salivary glands, and occasionally the pancreas. So again, this could be because of an abscess, or we could be actually going in and removing some of the stones from that area. Again, we can also do biopsies. You'll see a lot of imaging guidance. So again, this could be because we want to know what's inside. Maybe it's infection. We could be looking possibly for a tumor of some sort. You know, it all kind of depends on what we're doing. And again, we can do a full excision of the glands themselves if we need to. And again, when you see that radical dissection, in this case it's radical neck dissection, it's probably going to be because of cancer. When it comes to the pharynx, adenoids, and tonsils, the biggest thing is, of course, the removal of the adenoids and tonsils, but that is not the only thing that we do here, of course. Again, drainages. A lot of people have issues with abscesses in the tonsils and tonsil stones. Now, years ago, doctors would just remove the tonsils and the adenoids for whatever reason. Sometimes they would just remove them because a sibling was having them removed. But then we learned a lot more about the adenoids and tonsils, and we know they're made up of lymphatic tissue, and we know that they assist us with our immune system. One of the big things that the tonsils do is they help with the filtration of any type of bacteria that gets into our mouth as we're swallowing our food and beverages. However, they can stop functioning, or they can get built up with that bacteria, and that's when we may have to do either an incision and drainage, or if the person's really having a lot of issues, they might remove the tonsils. It takes a while to get them removed. I got mine removed at 19. It took me about 4 years of consistently having strep throat, sore throats, all of these problems. And finally, I was able to see an ear, nose, and throat doctor, and that they agreed to take my tonsils out, not my adenoids. And that's just the palatine tonsils, the ones that you can see when you open up your mouth really wide in the back of your throat. And since then, I've never been diagnosed with strep throat or any type of infection in my throat. So that did help. But again, it's not something that they just readily want to do. Obviously, we can remove a foreign body from the pharynx. Just like in the respiratory system, it's not just children that will stick things in places where they shouldn't go. People can also choke on food. This could be someone who's elderly. This could be someone who just plain wasn't paying attention. And so again, we want to kind of keep in mind that if there's a natural opening, we can always remove the foreign body from it. That's going to be the easiest way. And I want you to see here, starting at 42820. These are tonsillectomies and adenoidectomies, okay? These are separated out by age, younger than 12 and age 12 and older. So again, doctors get paid a little bit more to perform surgery on children who are younger. And so this is how they separate them out. What we need to know is a tonsillectomy and adenoidectomy, just tonsillectomy, just adenoidectomy. As we move a little bit further down into our esophagus itself, we get to our esophagoscopies. Now, again, remember, endoscopies, endo means within, so these are going within the body. And again, we can either do transoral or transnasal. So there's a couple of things we need to know about these. It tells us, when bleeding occurs as a result of an endoscopic procedure, control of bleeding is not reported separately during the same operative session. So again, if there's a bleed, they're just going to take care of it. Now, again, we need to be careful because as we go further down the system from the mouth and nose or up the system through the rectum and anus, we need to know where we're ending, because where we end will determine which code we use. So an esophagoscopy includes examination from the cricopharyngeal muscles, which is the upper esophageal sphincter, okay, to and include the gastroesophageal junction, and may include examination of the proximal region of the stomach via retroflexion when performed. So this is what they're doing. They're going up the nose or down the throat. They are going to be looking at the entire esophagus as they go down, and they can either stop at the gastroesophageal junction, which is the lower esophageal sphincter, where the top sphincter of the stomach and where the esophagus meet, or they can go into the top part of the stomach. And when they mean via retroflexion, what they're doing is they are sticking the scope down into the top part of the stomach and then hooking, basically doing a U-E, doing a U-turn with that scope and looking up. And the reason why they're looking up is because a lot of times when people are having issues with acid reflux or issues with their lower esophageal sphincter, they want to see if there's any inflammation inside the top of the stomach, perhaps where that digestive juice and bile keeps hitting it. So again, we're not looking at the whole stomach, we're just looking at the top. We're really looking at the top of the stomach on the opposite end of the esophageal sphincter. So what we need to know is we need to know how far we're going to make sure it's an esophagoscopy. We need to know the approach, transoral or transnasal, and are we doing anything else? Remember, a diagnostic scope is going in and looking around. The second we start using something else, it becomes surgical, and then we have to look for what else are we doing this with. So as we go down, this is our main code, but remember, this is an esophagoscopy, rigid transoral with diverticulectomy of the hypopharynx or cervical esophagus with cricopharyngeal myotomy, includes use of telescope or operating microscope and repair when performed. Again, that's that entire code. But as you see down here, this is our brushings and washings. So this is our diagnostic, okay? Transoral, so going through the mouth. And then again, we'll see as we continue to go, all of these are indented underneath code 43193. So we have to be careful. So these are all going to be considered transoral. But if you continue going down, now 43197 has a esophagoscopy flexible transnasal diagnostic. And then it has all of the different surgical codes that can go with them. Now keep in mind, they may do multiple procedures while they're scoping a patient. So we need to know what they're doing. Okay, so if they're just doing brushings and washings, that's a diagnostic. If they're doing brushings and washings and then they're doing an injection of sclerosis and esophageal varices, well, then we're going to need to make sure that we code just for 43204. But if we're taking a biopsy and doing an injection of a sclerosing of sclerosis for esophageal varices, we're going to need to code 43202 and 43204. So keep in mind, a lot of times they go in as a diagnostic. If they see something and they want to perform a procedure, remember, a lot of times they explain to the patient ahead of time, listen, this is what we're going in to do. If we see A, we want to do B. If we see B, we want to do C, et cetera, et cetera. So we need to be careful of the approach and what else we're doing with these codes. Same thing will go for all the different scope procedures in this area. Now we get to page 291, we get to the EGDs, the esophagogastroduodenoscopies. This is a scope going through the esophagus, the stomach, and the duodenum, which is the first part of the small intestine. So now we're going down further, okay? We're going down a lot further into the system. We're going through the stomach and looking at the small intestine. So this is what is interesting. For both upper GI studies, which this would be, and lower GI studies, sometimes we can't get through the natural passage because of blockages, okay? So we have modifiers we are going to use, and they tell us which ones. So they tell us to report an esophagogastroscopy where the duodenum is deliberately not examined, either because it's judged not clinically pertinent, maybe they found a huge gastric ulcer so they know what the problem is, or because the clinical situation precludes such an exam, like significant gastric retention, meaning that there's still food and beverages in the stomach, which means we really can't go through the stomach. We will not be able to see what's going on. So this is what we do. We append modifier 52 if a repeat examination is not planned, because modifier 52 is a reduced service. So what we're saying is we either found the problem ahead of time or we just can't do this because of an issue that we have to try to fix in another way. Or modifier 53 if a repeat examination is planned, because modifier 53 is the discontinued. So for modifier 53, the surgeon will get paid up and until they stop doing the procedure. And then when the patient comes back in, they will also get paid for doing the procedure, because the first time we told the insurance company there was a problem. And how would we describe that problem? Otherwise, in modifier 53, that would be again on the diagnostic side that would back up the modifier on the procedure side. So again, most of these are flexible transoral. What are we doing with them? You can see here that there's the picture right there. Oh, hold on, there we go. Again, this is also known as an EGD or an upper GI study, sometimes known as a UGI. Then we also have our endoscopic retrograde cholangiopancreatography. So this is a scope procedure where we're looking and recording the gallbladder, the bile ducts, and the pancreas. And retrograde usually means that we are using some sort of a contrast of some sort, but not always. So usually when we're doing these, we're doing them because there is an issue with the gallbladder, the bile ducts, the pancreas, or all of it. Again, there could be stones stuck in there. There could be a hardening or a shortening of one of the bile ducts. There could have been a laceration. And so when we're dealing with these, we want to know, what is the surgeon doing? So it tells us that the therapeutic ERCP codes always include the diagnostic ERCP. So remember, all surgical scopes, in this case therapeutic, is like a surgery because we are trying to fix an issue. ERCP includes the guide wire passage when performed. So a lot of times what we're doing with these scopes is we are using a guide wire so that we can see where we are, because that patient is usually on an operating table, but there's x-ray above them. And so there's a live feed of the x-ray, and so they can see exactly where that guide wire is to make sure they're in the right place. Now, an ERCP is considered complete if one or more of the ductal systems, pancreatic or biliary, is visualized. To report ERCP attempted but with unsuccessful cannulation of the ductal systems, see 43235 to 43259, 43266, and 43277. So again, there's always going to be patients with those exceptions that have issues that we can't fix right now. We may have to do another surgery. We may have to rethink the surgery. So again, we want to know, are we able to get into the system or not? So what we usually do here is we're sticking a very small scope down the esophagus, into the stomach, into the duodenum, and then scoping back into the biliary system, because remember, the biliary system comes out just about right next to the opening of the lower sphincter for the stomach, of the pyloric sphincter. So we can go and we can put that little probe in there to see what's going on. So codes 43274, 75, 76, and 77 describe ERCP with stent placement, removal or replacement, the exchange of stents, and balloon dilation within the pancreatobiliary system. For reporting purposes, ducts that may be reported as stented or subject to stent replacement or exchange to balloon dilation include the pancreas, all of its major and minor ducts, and the biliary tree, which is made up of the common bile duct, the right hepatic duct, the left hepatic duct, and the cystic duct, which goes to the gallbladder. So again, these are where we can put these stents. So again, remember, the stent is to hold something open. So we can use stents in the cardiovascular system, we can use them in the lymphatic system, we can use them in the digestive system, anywhere where there's a passageway that we need to hold open, we can use these stents. Now, ERCP with stent placement includes any balloon dilation performed in that duct. So a lot of times what we do is we go in with this little balloon and we kind of open up the area so we can see it a little bit better. And then usually if we're going to put a stent in, we use that balloon to open up the stent as well. Now, again, a lot of times stents are put in because of a variety of issues. One of the more common issues is stones that have lacerated the sides of the ducts themselves. Now they're becoming hardened or they're starting to close on each other. So this is to prop the vessel open. So ERCP with more than one stent placement, either a different duct or side by side in the same duct, performed during the same day or session, may be reported with 43724 more than once with modifier 59 appended to the subsequent procedure. Because again, in this case, they're telling us they're different stents. So we don't use 51 as the same procedure, we use 59 because they're different stents. For ERCP with more than one stent exchange during the same day, or session, 43276 may be reported for the initial stent exchange, and 43276 with modifier 59 for each additional stent exchange. So again, we want to kind of keep in mind that we might be inserting these or we might be replacing these. So it goes on to tell us to report the ERCP via altered post anatomy. We have a lot of different codes there, and again, this is because again, people could have had the gallbladder removed already, they could have had a reconstructive surgery, they could have had one of the gastric bypass surgeries done. So we have codes to describe all these different circumstances. We have a temporary code that includes optical endomicroscopy, again, 0397T. If the insurance isn't going to pay for it, then we need to be careful in whether or not our doctor is using this. But again, you might be working with a doctor who's still going through testing and who's dealing with seeing how useful these different procedures are. Now, again, they also talk about stone destruction. Again, stone destruction includes any stone removal in the same ductal system. So again, biliary or pancreatic. So again, it's all included as long as we're staying in either the biliary system or the pancreatic system. So again, what are we doing? Are we doing a diagnostic, going in and looking around and seeing what's wrong? Or are we going in and doing something else to actually fix a problem? So again, here's the diagnostic, and then all the other codes fit underneath it as all the different procedures that we could possibly be doing. As we move further down the system, we get to the laparoscopies, because we have to remember that most of our digestive system is in the abdominal pelvic cavity. Again, we have to remember that our esophagus does go through the thoracic cavity, but the majority of our organs are in fact in the abdominal pelvic cavity. So it reminds us that a surgical laparoscopy always includes a diagnostic laparoscopy. Again, surgical always includes diagnostic. If we're just reporting a diagnostic laparoscopy, we're going to use code 49320. Okay, so again, if we're just going in and we're looking around, but if we are doing something, then we have to be careful, because then that becomes another code. And again, what are we doing? In what area are we in? Because laparoscopic surgery can be used for the digestive system. It can be used for the reproductive systems. It can be used for the urinary systems. We can do some thoracic surgery through the abdominal cavity. So again, we have to be careful. What are we doing? These specifically are dealing with the esophagus and the stomach. So we're looking for the esophagomyotomies. We also have the laparoscopic fundoplasty, which you have a picture of on page 297 in your book. The laparoscopic fundoplasty that you see here, you can see they take the top of the stomach and they suture it around the the lower esophageal sphincter. And that's again to make sure that there is an area that can keep it closed. So people that have issues with their lower esophageal sphincter not closing, sometimes will get something like the fundoplasty. Now we want to be careful with these, because as we continue to go down, we have to remember that we can do reconstructive stomach surgery, and then we have gastric bypass, which is in a separate section. So just keep that in mind. So when we get to the stomach, again, we have to remember that we can make incisions from the outside of the body in. So we can do something like a gastrotomy with exploration of foreign body removal. So if someone swallows something and we can't get it out through the esophagus, we can make an incision into the abdominal cavity and into the stomach to go and remove it. But again, be careful. We also can do biopsies of the stomach. Of course, we can remove different types of ulcers from the stomach. And then you start seeing these gastrectomies right here with the Roux and Y reconstruction. So years ago, this was the most typical type of gastric bypass they did. But now we have the sleeves and we have the bands, and those are now a separate section coming in a couple of pages. That's now under bariatric surgery. However, a lot of times what we're doing now when we do these procedures, these gastrectomies, is going to be because of traumatic accidents and injury, and things like cancers and other extensive diseases. And so again, when we're doing these reconstructions, we have to be careful. If it's because of gastric bypass surgery, that is a separate section. These are reconstructions on the stomach for other reasons than weight loss. And as it goes on, it reminds us that, again, under our surgical laparoscopies, always include diagnostic laparoscopies. And this is where we start seeing the words gastric restrictive procedures. Okay, so the first set of codes is for different types of repairs. Now we're starting to see some of the gastric restrictive procedures. Now, when it comes to the gastric restrictive procedures, some of them go by how much did we remove? Because what we do with these procedures is we usually remove a pouch of the stomach and then make a reconnection of the small intestines. we look on the right-hand side of the page, we see introduction. Remember, introduction, we are introducing something to the body. These are feeding tubes. So this is what we call NG and OG tubes for nasogastric or orogastric tubes. Now, these are done for a variety of purposes, okay? Now, the biggest thing here, a lot of times they're done for little babies. This is included in the neonatal critical care and pediatric critical care codes, so be careful. But if we're doing this for another reason, so again, if we have a child that has a very extensive cleft palate, they may get, and they most likely would get, an NG tube, which means it would go up the nose, it goes down into the esophagus, into the stomach, and they will be able to get their formula through that way. We also can go through the mouth, which is less common. We go through the mouth for these, usually the person is either in like a coma-like state or an induced coma because it inhibits their talking. But again, a lot of times we are going to see the NG tubes. And again, we can do these for cleft lip, cleft palates, other congenital craniofacial anomalies, and also if we need to get nutrition into the patient fast. There are quite a few burn units around the country that they have been giving their severe burn patients extra protein-based food products through a nasogastric tube, and the extra proteins actually helping them regrow that skin that they need to be able to make sure they don't get infections. So it's kind of interesting. We can also do gastric intubation. This is to kind of see what else might be going on in the stomach, especially if someone, is having a lot of issues or they're feeling a lot of acid come up. We can go in and we can actually remove some of that just to look for it. And then we finally get to our bariatric surgery. And our bariatric surgery, again, reminds us that the surgical laparoscopy always includes a diagnostic laparoscopy. Now, this is what's interesting though. As they remind us, typical postoperative follow-up under the surgery guidelines after gastric restrictive using the adjustable gastric restrictive devices includes subsequent restrictive device adjustments through the postoperative period for the typical patients. Adjustments consist of changing the gastric restrictive device through a component diameter by the injection or aspiration of fluid through the subcutaneous port component. So these are basically like the gastric bands. So what they do is the band itself goes around part of the stomach, and the surgeon decides how much of the stomach they want the patient to get, usually about a half a cup to a cup size. They put the band around it, and then attached to the band is a little catheter that then connects to a subcutaneous port. Subcutaneous port can be accessed by the doctor easily, and they can inject things like saline to make the band tighter, or they can release some of it to make it a little bit looser. And a lot of these things are going to be done in those 90-day periods as the patient follows up and as they might have some pain or discomfort, the doctor can adjust it for them. That is all inclusive. After the 90-day global period, though, or if there are any complications, that's when we might see some of these other ones. So we might see a revision. This could happen months afterwards. I once met a lady who had gotten the gastric band done about a year before I had met her, and then she told me that she had to go have surgery because her gastric band had opened and had floated in her abdominal cavity down to near her appendix. So they had to go in and they had to remove the gastric restrictive band that was already in and replace it because it did pop open. So again, that was after her 90-day global period. So we have to go back to the code setting. Now, when it comes to the intestines, a lot of times people have to remove intestines because of either accident or injury or because of very extensive disease process. Things like Crohn's, things like colitis, diverticulitis can end up leading to a person having to lose part of their intestines because of chronic inflammation. All right. As with all of our transplants, we're also going to see 3 parts. But unlike the transplants we've looked at so far, which is the lung and the heart, The intestines can be a cadaver donor or a living donor. So again, we need to know, is it a cadaver donor or living donor? And then again, what is our provider doing? So again, the enterectomy, removal of the intestinal graft and making sure it stays cold in between patient A and patient B. The backbench work, which again is preparing it. So again, we're looking at things like the mobilization and fashioning of the superior mesenteric artery and vein. Again, we might need to do a venous or arterial anastomosis. So again, a reconnection. What are we doing? The backbench work, preparation for all of this. And then, of course, we have the transplantation itself. So again, we need to know, what are we doing for this patient? Okay, what is our surgeon doing? Are they doing 1, 2, or all 3 parts for this person? And again, as always, care of the recipient is part of it if it is a living donor. So again, for this, you can look under enterectomy, or you can look under transplantation or intestine. Now, when it comes to the laparoscopies where we're dealing with our small intestines, again, what are we doing with it? So again, in this case, we're doing an enterolysis, a freeing of intestinal adhesions, which is when the intestines themselves basically become connected. And that could be because of scar tissue or a variety of other problems, especially ectopic tissue that can grow there and actually connect them. When we get to the endoscopy of the small intestines, again, we have to be careful. So this is when we're going further down past the duodenum into the small intestines. So it reminds us yet again that when bleeding occurs as a result of an endoscopic procedure, controlled bleeding is not reported separately. Okay, so again, if the patient starts to bleed, that is considered part of the procedure for them to stop the bleed. Now, they go on to tell us that antegrade transoral small intestinal endoscopy or enteroscopy is defined by the most distal segment of the small intestine that is examined. So remember, distal, distance, so the furthest intestine that we're going to. Okay, so we need to know how far are we going through. So 4, 4, 3, 6, 0, 1, 3, 4, 5, 6, 6, 6, 9, 70, 72, and 73 are endoscopic procedures that visualize the esophagus through the jejunum. And then 4, 4, 3, 7, 6, 7, 8, and 9 are endoscopic procedures that visualize the esophagus through the ileum. So again, we're going even further down to the third part of the small intestine. Okay, so again, how far are we going into the system to perform these procedures? Now, we're going to see these definitions a couple different times. So I highlighted them once. I didn't do it every single time, but you certainly can, because the definitions don't change. So one of the big things is, how far are we going into the system, whether we're going through the mouth or whether we're going through the anus. So a proctosigmoidoscopy is examination of the rectum and may include examination of a portion of the sigmoid colon. So remember, as we're going up the system, we get anus, rectum, sigmoid colon, and then if we continue going up the system, we get descending colon, transverse, ascending, and then cecum. So again, the proctosigmoidoscopy is looking at the anus and rectum and may look into the sigmoid colon. A sigmoidoscopy is the entire rectum, the entire sigmoid colon, and may include looking at a portion of the descending colon. All right. A colonoscopy is examination of the entire colon from the rectum to the cecum, and may include examination of the terminal ileum or small intestine proximal to an anastomosis. So a full colonoscopy usually goes all the way until where the small intestines and large intestines meet. Where the small and large intestines meet is considered the cecum itself. Now, if someone has a new opening in the digestive system, we can do a colonoscopy through a stoma. And so again, if someone has a colostomy stoma, what we're going to do is we're going to go from the colostomy stoma to the cecum or colon small intestine anastomosis. Again, it may include examination of the terminal ileum or small intestinal proximal to the anastomosis. So again, remember, a stoma is a new opening, and a lot of times it's a new opening to the outside, the bottom. So a colostomy is a new opening from the colon to the outside of the body. Remember, if we have a new opening, we're going to scope through that new opening before we're going to do anything else, because that is going to be the easiest way to get into the system. Now, just like for our upper GI studies, when performing a diagnostic or screening endoscopic procedure on a patient who is scheduled and prepared for a total colonoscopy, if the physician is unable to advance the colonoscope to the cecum or colon small intestine anastomosis due to unforeseen circumstances, report 45378 or 44388 with modifier 53 and provide appropriate documentation. The most common cause of the reason why we could not finish performing the colonoscopy is due to a bad preparation. In the last 15 years, they have opened up and then closed up a lot of different preparations for patients to use for colonoscopies. Some of them were very effective, but if people were not doing them correctly, it leads to feces being in the system. And we want the system to be as clean as possible so we can see if there's anything that should not be there. Now again, the biggest thing is, if a therapeutic colonoscopy is performed and does not reach the cecum or colon small intestine anastomosis, report the appropriate therapeutic colonoscopy code with modifier 52 and provide appropriate documentation. And again, that's because we had to stop the procedure because, again, of an unforeseen circumstance. We also have an ileoscopy through a stoma, 44380, 381, 382, and 384 for endoscopic examinations of a patient who has an ileoscopy. And we report a colonoscopy through a stoma, 44388 to 44408 for endoscopic examinations for a patient who has undergone segmental resection of the colon. So a hemicolectomy, taking out half the colon, a sigmoid colectomy, removing the sigmoid colon, a low anterior resection, basically anyone that has a colostomy. And yet again, as we saw before, when bleeding occurs as a result of an endoscopic procedure, controlled bleeding is not separately reported. So again, keep in mind, how far are we going and are there any complications? So we're going to see the ileoscopy through a stoma first. Then as we continue going, we are going to see some of our other endoscopies. We're going to see the colonoscopy through a stoma. We're going to see the colonoscopies done in a variety of different ways. We also have a small section called Meckel's diverticulum and the mesentery. So again, this is part of the fatty layers of our abdominal cavity. And so again, for these, you can look up mesentery or Meckel's diverticulum for these procedures. There's not many, there's only 4 of them. We then get to the appendix. Again, we can do an incision and drainage. If the infection is small and the doctor does not feel like the patient needs their appendix removed, then we will do an incision and drainage. If it has rotted or it has burst, then we will do a full appendectomy. The biggest thing with the appendix is similar to the tonsils. Now, here's what's interesting. The appendix has no known function in the digestive system, okay? We don't know what it does. What we do know is it's made up of lymphatic tissue. So although we don't know what it does, we do know what it could do for us. And so again, they try not to remove it unless absolutely necessary. And then, of course, we have the laparoscopic appendectomy as well. So we have open procedures, and then we have the laparoscopic. And that a lot is going to depend on the patient and the surgeon who's performing that surgery. Then we get to the colon and the rectum. So again, the biggest thing here is what are we doing? So we can have incision and drainages of different abscesses. Again, we can have tumors, we can have swollen twisted veins. So what specifically are we doing in this area? And again, you're going to see at the bottom of page 312 the same exact definitions that we've already looked at. And so every time we come up to a new section of scopes, we're going to have another area where it's going to give us guidelines. However, basically, they are giving us the same exact guidelines on page 313 as we found on page 308. So when you get there, this is what I wrote. I wrote page 308 guidelines. It's the same exact guidelines. There is nothing different. They just plop them here as a reminder. So again, we need to know, what are we doing? Are we doing a proctal sigmoidoscopy? Are we doing a sigmoidoscopy? Are we doing a diagnostic where we're looking around? Are we doing a surgical or therapeutic where we're doing something? What are we doing? Now, on page 314, we have this lovely colonoscopy decision tree. This is very, very helpful. Again, it gives us which modifiers go with them if we can't go beyond certain areas. And so this can be really, really helpful to your coding. Then we start going towards the anus and rectum. One of the first things that we are going to see here is we're going to be dealing with hemorrhoids. Hemorrhoids are swollen, twisted veins. We have something called esophageal varices. Those are swollen, twisted veins in the esophagus. So what they're telling us here is we can do incisions, we can do excisions, and we can do removals of them. So for incisions of thrombosed external hemorrhoids, use 46083. For ligation of internal hemorrhoids, see 46221, 46945, and 46946. For excision of internal and or external hemorrhoids, see 46250 to 46262 and 46320. For injection of hemorrhoids, use 46500. For destruction of internal hemorrhoids by thermal energy, use 46930. So again, it's just telling us, for this, use this. For destruction of hemorrhoids by cryosurgery, use 46999, which is our unlisted code. For a hemorrhoidopexy, use 46947. Do not report 46600 in conjunction with 46020 to 46942 or any of the temporary codes during the same session, because 46600 is a code that, again, we have to be careful. What can we use? What can't we use? 46600 is an anoscopy diagnostic. So again, if we're going in and looking around, that's part of a procedure. So again, we can't code a diagnostic procedure when we're going to be going in and looking around as well. So again, what are we doing? Are we doing an incision and drainage? Are we doing a full-on excision? So we have 4 different degrees of hemorrhoids. So what I've done is I wrote on page 319 in my book the different types that we're going to see. Okay, so a first degree hemorrhoid is inside only. So there's just a swollen twisted vein inside the rectum and anus. A second degree comes out and back in the body by itself. So it means it can come out of the body and then it can go back in without having to have anyone do anything to it. A third degree is completely outside of the body, but the hemorrhoids can be pushed back inside the body. And a fourth degree is completely outside and cannot be pushed back. So as we go up in degrees, we go up in complexities. And here's the thing that we have to remember. We're talking about basically a tube. So a lot of times these hemorrhoids are going to come in these clusters, or what they call columns here. And so what we need to know is, what are we removing and how many are we removing? Because again, we have internal and we have external. We also need to know how. What is the approach to the removal? Are we going to be doing a rubber band ligation? Are we doing a full-on excision? What is the actual issue? Then we get to our accessory organs. It starts with the liver. So the liver itself, again, we have transplantations for it. Again, you can get half a liver. So we're going to have both a cadaver donor hepatectomy and a living donor hepatectomy. But again, what is our surgeon doing? Are they doing the removal? Are they doing the backbench work? Are they doing the transplantation? Are they doing all of that? And again, the biggest thing here is, remember, the backbench work is preparing the graft itself. So again, if it's a whole liver graft, it's going to include a cholecystectomy and removal of surrounding tissues, preparing the vena cava, the portal vein, the hepatic vein, the common bile duct. If we're doing a liver graft, again, what are we doing with that graft specifically? So keep in mind, we could be doing part of a liver or an entire. Remember, the liver is 2 lobes of it. So again, similar to the intestines, is this a living donor or is this a cadaver donor? And again, what is our surgeon doing? Now, because we're getting scopes that are a lot smaller, we talked about this in cardiology, we are seeing a lot more procedures where we are trying to go in through natural orifices and we're making incisions as small as possible. So the percutaneous biliary procedures that we see here are relatively new. These came in the last few years. And again, these are ways that we can go in and perform endoscopic procedures instead of slicing and dicing the patient from the outside. So let's see what we can do here. The percutaneous biliary procedures are described by 47490 and 47531 to 47544 and are performed with imaging guidance. Okay, so they're always performed with imaging guidance. They are differentiated from endoscopic procedures that utilize access to the biliary tree from a holus viscus from diagnosis and therapy. A diagnostic cholangiography is typically performed with the biliary procedures and is included in all of these codes. So what are we doing here? Codes 47531 and 47532 describe percutaneous diagnostic cholangiography that includes injections of contrast material and all associated radiological supervision and interpretation and procedural imaging guidance. So what we're doing here in these codes is we're looking at the vessels themselves, what might be wrong with them. Now, that goes on to tell us, an external biliary drainage catheter is a catheter placed into a bile duct that does not terminate in bowel, so in the actual intestines itself, and that drains bile externally only. An internal external biliary drainage catheter is a single externally accessible catheter that terminates in the small intestine and may drain bile into the small intestine and or externally. A stent is used in this code set. It is a percutaneously placed device, a self-expanding metallic mesh stent or plastic tube, that is positioned within the biliary tree and completely internal with no portion extending outside to the patient. So again, we can drain the bile outside the body or we can drain it into the small intestine if there is an issue with the biliary system itself. Now, again, it goes on to tell us that these codes 47533, 3, 4, 5, 6, 7, 8, 9, and 47450 describe percutaneous therapeutic procedures that include catheters or stent placements, catheter removal or replacement, so an exchange or catheter removal. So again, these are percutaneous, so we're going through the skin into a vessel. These codes include all the elements of access, so getting there, drainage catheter manipulations, moving the catheter where we need it to be, diagnostic cholangiography imaging guidance, making sure we're in the right place, and all associated radiological supervision and interpretation. However, it tells us 47533, 34, 38, 39, and 40 may be reported only once for each catheter or stent placed. So again, only once for each catheter or stent placed. So what happens when we're doing multiple? That's what we're going to find out. So codes 4, 7, 5, 3, 8, 3, 9, and 40 may be reported only once per session to describe one or more overlapping or serial stents placed within the single bile duct or bridging more than one ductal segment, like the left hepatic duct and the common bile duct through a single percutaneous access. Okay, so again, those codes can be used only once in the same session, but it goes on to tell us codes 4, 7, 5, 3, 8, 3, 9, and 40 may be reported more than once in the same session using modifier 59 for additional procedures in the following circumstances. So this one we can code it a second time with a modifier 59, either if placement of a side-by-side known as a double-barreled stent within a single bile duct. So again, exactly what it says, directly side-by-side. Placement of 2 or more stents into separate bile ducts through a single percutaneous access. So again, still 2 stents, but 1 access point. Or placement of stents through 2 or more percutaneous access sites. So again, doing it more than once. So more than 1 percutaneous access point. Those are when we can code it separately. So we need to be careful. When can we and when do we not? Now, it goes on to tell us, code 47541 describes a procedure to assist with the endoscopic procedures performed in conjunction with other physician specialists. Access placed may include wire and/or catheter. Code 47541 may not be reported if a wire is placed through an existing percutaneous access. So again, are we doing something else with this procedure? We need to be careful. Codes 47542, 43, and 44 describe procedures that may be performed in conjunction with other codes in the same family that are add-on codes and do not include access, catheter placement, or diagnostic imaging. So again, be careful. What are we doing in this specific area? And again, only 1 code per stent or catheter. So each stent or catheter gets its own code. Okay, the biggest thing here is, again, be careful. How many percutaneous access sites do we have? So again, we have percutaneous ones, and these are newer codes, smaller procedures. Instead of slicing and dicing, we're going in and we're making as small of an incision as we possibly can. Then we get to, again, the pancreas. So remember, when it comes to accessory organs, we've looked at the liver, we've looked at the gallbladder and the biliary tract, and now we're getting to the pancreas. So again, in this case, like the lung and the heart, the pancreas is not something that you can donate living, and you can't donate part of it. So it's an all or nothing. Now, here's the big thing about the pancreas. You can live without the pancreas. Remember, on the diagnostic side, we have post-pancreatectomy diabetes mellitus. When the person needs to take insulin on a daily basis because they don't have a pancreas anymore to produce it because we've removed the pancreas. However, if we can get a pancreas, that just helps more with the body's processes. So again, in this case, what is our doctor doing? Are we doing the pancreatectomy, the removal? Are we doing the backbench work? Again, in this case, we're going to make sure that it's dissection from surrounding tissues. We might also have to do a splenectomy, a duodenotomy, a ligation of bile ducts, ligation of mesenteric vessels, and a wide graft arterial anastomosis from the iliac artery to the superior mesenteric artery and to the splenic artery. Why? Because again, we need to make sure when we're not just placing the organ in, we have to make all the reconnections for his blood supply as well. And again, it goes on, additional reconstruction may include a venous anastomosis. And then, of course, the allotransplantation. So what is our surgeon doing? Okay, are they just doing the removal? Are they doing the backbench work? Are they doing the allotransplantation? Or are they doing all of it? Now, earlier we talked about the NG and OG tubes, okay? So these are gastrostomy tubes, duodenostomy tubes, and jejunostomy tubes. So it tells us, do not additionally report 43752 for placement of a nasogastric or oral gastric tube to insufflate the stomach prior to percutaneous gastrointestinal tube placement. NG or OG tube placement is considered part of the procedure in this family of codes. So NG and OG tubes are going either up the nose, down the throat into the stomach, or in the mouth, down the throat into the stomach. Okay, these are going to be used for a much more permanent solution. They can still be considered temporary. A lot of times we're going to do these again. Traumatic accidents and injuries are a big one. Congenital anomalies, where the craniofacial area is not good for the child to be able to get down their food. And we also do a lot of this for extensive diseases like cancer. So again, if someone has like esophageal cancer or oral cancer, a lot of times they're not allowed to eat. How do they get their food? They get it through a gastrostomy tube going directly into the stomach, or a duodenostomy or jejunostomy. The idea of these tubes is we're completely bypassing an area so the patient does not have to get in food that way. So again, we can put it, again, now this is going to come from the outside of the body. This is going to be a little port that they can connect the actual food to, the food bags. So again, what are we doing? Are we inserting it? And where are we inserting it? Are we we can also do a cecostomy, which is much less common, but can also be done for stomach and small intestinal cancers as well. We could also do a conversion of a gastrostomy to a gastrojejunostomy tube. So again, we can change where the tube is. And of course, we can also remove them as well. So when they finally need to be removed, then we can actually go in and say, okay, this is what we've been doing. This is how we're going to do it. And of course, we have our replacements. Now, the big thing with replacements is, again, if an existing gastrostomy, duodenostomy, or jejunostomy, or gastrojejunostomy, or cecostomy, or other colonic tube is removed and a new tube is placed via a separate percutaneous access site, the placement of the new tube is not considered a replacement. It would be reported using the appropriate initial placement code. So again, if we are moving where we originally placed this tube, it's considered to be an initial placement code. If we are replacing the tubing, it is just a replacement. So we need to know, again, if we're going in, are we replacing, or are we actually moving where the insertion site is? Then we get to our hernias, okay? So we get to our hernioplasties, our herniorrhapes, and our herniotomies, okay? So again, hernias, most of the time, when people think of a hernia, they think of part of the small intestine going through one of the muscle walls, and that's usually what it is. It can also be the colon. On occasion, it could be another organ. Technically, a hernia is an organ or part of an organ pushing through the wall of another organ. So again, it could be the small intestines pushing through the wall of the muscles on the abdomen or the pelvis. So the first thing, and by the way, all of this that we need to know on the procedure side are the exact piece of information we need to know on the diagnostic side. So no matter which way you're doing it, we're still matching up all of this. So we need to know the type of hernia, okay? Is it inguinal? Is it femoral? Is it incisional? Okay, so again, where is it? Then some hernias are further categorized by initial or reoccurrent, because again, some people can have reoccurrences of these, and we can maybe fix it more than once for them. Now, there are some other variables here. Again, patient age and clinical presentation. Reducible, incarcerated, or strangulated. I have some definitions. We'll look at that in a minute for those. The only exception is for incisional hernia repairs. Again, where we use prostheses, we use like a mesh. And again, the mesh itself is not separately reportable. However, the excision or repair of strangulated organs or structures such as testicles, intestines, or ovaries are reported using the appropriate excision of repair code from their specific sections. Again, we need to be careful. So for instance, we see things like 49491. Repair of initial inguinal hernia preterm infant younger than 37 weeks gestational age at birth, performed from birth up to 50 weeks post-conception age with or without hydrocelectomy, reducible. Or it could be incarcerated or strangulated. So if it's a young baby, we have to be careful, because a lot of times the more premature a child is, the more we tend to see these types of hernias, because the cell signals to finish closing the areas have not finished yet before they're born. So we actually can go in and perform these surgeries when they're very, very young. We also have them, again, they explained to us that post-conception age equals gestational age at birth plus age of infants and week at the time of the hernia repair. Okay, so again, we have to be careful about how old are these babies for dealing with little babies. Then we have, other than 6 months, we'll have ones for younger than 5. We have ones for older than 5. But here are some definitions that you should have. So strangulated means the blood supply is cut off. So again, it's completely strangulated. Versus incarcerated means it can't be returned to the abdominal or any cavity really, which means it basically, a lot of times it starts necrotizing or becomes gangrenous. Because again, it's also usually strangulated as well. So these two, again, we need to know the type of hernia. If it's a small child, we need to know the age of the patient. And if this is a recurrent condition, again, we need to make sure that we get the recurrent codes. All right, guys, digestive, remember, look for the body part, look for the direct name of the surgery, or in this case, we can look up the word hernia, and we're going to find these codes. Good luck.